My name is David Austin. I'm a consultant cardiologist at the James Cook University Hospital in Middlesbrough. I'm an honorary clinical senior lecturer at Newcastle University in the UK. This is an important study for the survivors of breast cancer and non-Hodgkin's lymphoma. These patients receive cardiotoxic medications as part of the management of their primary disease. And really, this is about trying to reduce the impact of these important therapies on the quality of the patient's survival. So PROACT, which is a study looking at aiming to prevent the myocardial injury or the cardiac damage associated with anthracycline chemotherapy. So anthracycline chemotherapy, such as doxorubicin or epirubicin, are commonly used in conditions such as breast cancer and non-Hodgkin lymphoma. The study is a multi-center randomized control trial assessing the ACE inhibitor enalapril to determine whether enalapril can prevent the myocardial injury that occurs during chemotherapy and prevent what's called the CTRCD, so cancer therapy-related cardiac dysfunction that can occur. The primary endpoint of the PROACT clinical trial was detection or myocardial injury as determined by highly sensitive cardiac troponin T. We also had secondary endpoints including cardiac troponin I and cardiac function assessed by echocardiography. These are all done in a blinded fashion in core laboratories to ensure that ensure the quality essentially of the findings. And we found that enalapril, when titrated to 20 milligrams daily, did not impact the myocardial injury caused by anthracycline chemotherapy. This was consistent across both troponin T, troponin I, and across the cardiac function measured by LV global longitudinal strain and also left ventricular ejection fraction. What we have is a negative findings, if you like, but this is a definitive answer in this particular area, particularly because we recruited patients with the highest dose anthracycline chemotherapy and therefore one of the main risk factors for developing heart failure at a later stage. So we feel that this study would suggest that we should not be really studying enalapril any further in this setting in terms of preventing. Although the current guidelines suggest we should be monitoring these patients closely. And it might be if they develop cardiotoxicity subsequently that these therapies can be useful still, but perhaps not in a preventative fashion given prior to the commencement of chemotherapy. So the next steps for the PROACT trial is for us to follow the patients up for longer with late echocardiography, late clinical follow-up to make sure there's not a delayed effect or even a delayed benefit of the enalapril in the setting. I think it's also important that we look as a cardio-oncology community of researchers to see if we can maybe try and pool some of our data because these clinical trials are very challenging to perform and perhaps understanding some of the event rates, for example, moderate or more severe cancer therapy-related cardiac dysfunction, to help us plan future trials.